We have a couple of minutes for questions, and I apologize in advance if I don't get to your questions. This question is for Bill. Bill, for an infant with a non-infected dacryoceal without respiratory distress, what is your timing for going to the OR if conservative management is ineffective?
If it's bilateral, I consider it a surgical problem. If it's unilateral, I really hope that it can be decompressed with mild massage through the lid, because ultimately you're trying to put hydrostatic pressure on the cyst. And sometimes I've actually scheduled patients for surgery, and the parents will call and they'll say, it just went away suddenly. And that's what we hope will happen. So once again, unilateral, I'll probe a dacrocystocele that I can't decompress with massage in the office, being aware that they could go into respiratory distress. So I never do it in a satellite. I only do it in my hospital-based clinic. And I'll watch them for sometimes weeks, but just aware that it could get infected. And once it gets infected in an infant, it can become an emergency within hours. So those are patients that are admitted for surgery.
Great. Next question is for Angela. What is your preferred method to secure lacrimal stents to prevent prolapse for endoscopic surgery?
I usually I don't secure it. I just tie a knot at the end. So I use lacrimal dilator. And then I do like three knots. I leave it, and usually there's no problem. If it does prolapse, I just take it out in the office, and I can take it out through the canaliculi, because with 3 knots it comes out easily, and there's no problem with. I mean, I just leave it more for my comfort if I have to have a stent, but. There are many studies that actually show that we don't really need silicone stents after DCR.
All right, our last question is for Dan. How many times can bleomycin be injected?
How many times, like over the course of a lifetime?
Yeah, over the course of a patient's maximal dose, and then if you can talk a little bit about...
Yeah, I mean, I think that I don't see why there would be a limit. I mean, it's the individual sessions that are going to be the maximal doses for the individual sessions. But it's water soluble, so by the time you bring them back, it's going to be completely gone from the system, totally eliminated. So I think that you can do multiple sessions. And I guess the real question would be like how far apart. Yeah, and I would wait, I usually would wait at least 3 months, because the patient has to go through this, the healing phase, and they don't really want to go back that much sooner.
Great, and just to add to that question, how do you control inflammation post-bleomycin injection? You mentioned that for the most part, you don't see this vigorous inflammatory response.
Yeah, I mean, that's an interesting question, which I actually don't really have a great answer for. I mean, one of the ways the bleomycin works is by creating inflammation inside the cyst. So you need that inflammation for it to have an effect. But at the same time, the ancillary aspects of the inflammation can cause problems, proptosis and dysfunction. So you want to calm that inflammation. So you're in a bit of a bind. And in general, I try not to use anti-inflammatories for at least the first 2 weeks, so that you can get at least the acute phase of the inflammatory reaction to do its job. And then if they have persistent swelling after that, then I would add it in. But I try not to be too aggressive with it, because you want some of that inflammation there.
That's great. All right, in the interest of time, we're going to go ahead and move on to section number 3.